antegrade wire escalation and parallel wire technique. I think first part, antegrade wire escalation, is already done by Dr. Rupali and Dr. Ashok. So I will focus more on parallel wire technique. Anyway, something will be repeated. I have nothing to disclose. Well, for the fellows, if you want to do CTO, you have to understand this slide. If you understand this slide, then you will have a clear concept of CTO. So remember this basic thing. In CTO, you have to connect the proximal true lumen with the distal true lumen, either antegradely or retrogradely, either by true to true lumen by wire escalation method, antegradely or retrogradely, or you can go to subintima, then again come back to the true lumen after crossing the CTO body. And also retrogradely, you can go subintima and come to the proximal lumen. So basic mechanism is very clear. You have to connect the proximal true lumen with the distal true lumen, either by wire escalation method or dissection and re-entry method. That's the basic. So if you understand this slide, all the mechanism sums up into this slide. So before doing CTO, if you want to do antegradely or retrogradely, you have to understand especially the anatomy of the CTO. It's very important, which has been described by my previous speakers. How is the proximal true cap? Is it blunt? Is it tapered? Is there any side branch? Is it calcified? So depending on that, suppose if it's a tapered proximal cap, you can probe it with some polymer jacketed wire like Fielder XT R wire, Fielder XT wire a bit harder, or Pilot 50. But if it's not tapered, it's blunt, then you have to need to penetrate the proximal cap with a harder wire like Gaia 2nd, Gaia 3rd, and even harder you have to use Confluenza Pro 9 or 12. So for CTO recanalization antegradely by wire escalation method, there are 3 steps: puncture the proximal cap, traverse the CTO body, puncture the distal cap. These are the 3 steps for crossing CTO antegradely: proximal cap, traverse the CTO body, distal cap. So then you have to determine the length of the lesion. I've said the segment of CTO. If length is less than 20 millimeter, we can try antegrade wire escalation method or parallel wire technique. If more than 20 millimeter, then dissection and re-entry. Then distal cap. After reaching here, if it does not go away, you again have to upgrade your wire. And sometimes we only talk about escalation. There is sometimes you have to de-escalate it as well. Like, when you're in a war in the Middle East, then sometimes you de-escalate it. So like that, after crossing this proximal CTO body, if you feel that there is less tissue resistance, loose areolar tissue, then you can change your CTO harder wire like Gaia 2nd or Confluenza Pro to Fielder XTR wire, because there is some microchannel, it passes very fast distally. So not only escalate, sometimes de-escalate your wire as well. But there are different algorithms. I'm showing it's one algorithm, and key point of doing CTO, especially antegradely, even if there is a collateral channel, you have to give dual injection. And if there's ambiguous proximal cap, not. If there's a poor distal tract is not poor, if appropriate, it is for retrograde, not for antegrade. So if this 2 answer is no, then you have to measure the lesion length. If it's less than 20 millimeter, then my topic is antegrade wiring by either antegrade wire escalation or de-escalation method or parallel wire technique. So it is a mostly used strategy in CTO PCI, though we talk about retrograde very often, but retrograde is very cumbersome and comes with complications. And you have to cross the algorithm. So the question was, how long should I try this? When you see that your wire is buckling or your wire is not in a intimal space, it's going to subintima, then it's a time to change your technique or wire. So Antegrade approach, true to true lumen, either single wire manipulation by wire escalation or de-escalation method, then parallel wire technique, and sometimes we do IVAS guided wiring as well. So while doing the wire shaping CTO is very important. You can have two bends, like 1 or 2 millimeter 30-degree bend, and then after 4 millimeter there could be 60 millimeter bend. This is the bend we often use, but sometimes to penetrate the proximal hard cap or distal hard cap, you can give this almost 60 to 90-degree bend after 2 to 3 millimeter with a harder wire. So these are the two ideal wire shaping for CTO crossing and penetrating the hard cap. So what are the basics of antegrade wire escalation? Escalation of wire tip to cross with microcatheter support. Always take microcatheter. Don't cross any CTO without microcatheter. Understanding the anatomy of CTO dictates wire selections, whether it is tortuous, whether it is straight, or whether it is there is calcium or not. And following cap penetration, medium weight polymer jacketed wire can be used. Escalation and de-escalation also is very important by your feel of the CTO resistance. If feel is not harder, then go for escalation. If feel is softer, then you can de-escalate to polymer jacketed wire. And always confirm wire position with orthogonal views and retrograde injections. And try to wire intraplug entire CTO by in the intraplug method before entering the distal true lumen. Then you will not lose the side branches. So usually we start with a slippery wire like Fiddler, XT-R, XT, Whisper, Pilot. Then if it fail, then we upgrade it, escalate it to Miracle 3 or Ultimate Bros or Gaia first. And then we go for Gaia second, third, now Gaia 2 next, Gaia 3 next. And even then if you can fail, then you can escalate to stiffer wire with taper tip, the Congress Pro 9 or 12. There are different algorithms and of the different wires and their properties. I've already explained by my previous speakers now. And there is a picture like tapered, you can see Fielder XT-R wire, some loose channels. Here is XT-A, then Gaia second, then Gaia third, then Conference Pro 12. A parallel wire technique, if one wire goes to false lumen, then we keep it there and take another wire which should be harder and a bit more bent. And then by the guidance of the first wire, we can take it to distal true lumen and penetrate the distal hard cap. So in parallel technique basics, when the first wire goes to submental space, keep it there and take the second wire. And don't take out the first wire because then you lose the information already gained. And always it will prevent the second wire to go into false lumen. And it also help to modify the vessel architecture and status its vessels. And second wire should be stiffer and first wire and with more curve at its tip. And always check relative position of the wire in different orthogonal views. There's a case example, you can see this is RCS CTO, but you can see there's some micro channels, though we're not sure which one to poke, but you have to take different views to see the correct micro channel. And then we took, by the help of microcatheter on Fielder XT wire, by sliding method, and it passed easily. So CTO done by 5 minutes. Putting stent, and this is the last picture. Same patient, you can see there is a retrograde collateral to LED CTO. So double catheter, and there is the LED CTO approximately 20 millimeter. So again, different orthogonal view to see the course of vessels. Now, I again probed with, tried with first with wire escalation method. I tried with Fielder XT wire, but I failed to penetrate the proximal cap. So then tried harder wire, Congress Pro 9 with microcatheter support. But unfortunately, it went to false lumen in the diagonal branch. So he pulled it out, tried a different path, again into the false lumen in the distal true vessels. So you can see the wire is out of the vessel architecture distally. Then went for parallel wire technique. The second wire was Conquest Pro 12. So keeping the first wire in the false lumen, tried the Conquest Pro 12 wire. It acted as a guide So this is parallel wear technique. And then inch by inch I proceeded and almost reached the distal cap, but did not puncture. You shouldn't puncture. So take two different orthogonal view. Then I directed my wire tip to the distal true vessels and punctured. And after passing that lesion, you must change the dilation into BMW wear because it can perforate. And this is the last picture after putting the stent. Okay. Okay. Sorry, I think time is up. So that's it.
I think only a few slides left. Can you just?
No, I'm done. I'm done. I'm done. Just take home message. Just take home message.
Please show the take-home message. Yeah.
Always try to double puncture, introduce double catheter, and always visualize the distal vessel for CTO intervention if there is collateral. First, try to probe with macro channel with CTO with slippery wear first. If you fail, then go for harder wear like Gaia Next or Conquest Pro. If first wear goes to false lumen, keep it there. Don't panic and try to take another second hardware for parallel wear technique and never lose hope. Keep the patient safety first. Thank you. That's it.
Thank you. Thank you very much. There is a question from.
Thank you very much for nice presentation and lecture also. I have a question. In parallel techniques, you show that there is a CTO, so both wire should covered by microcatheter. So two microcatheter is inside there. There is a in one wire you place in a false lumen, then you try to another wire.
Yeah.
So both wire are
No. There are three options. One is if one wire go to false lumen, what I did in this case, I keep the wire there. I take the macrocatheter out. Then I take second wire with the microcatheter. One. Second, you can use a double lumen catheter like Sasuke. Double lumen catheter, you can take the over the first wire, and there is another hole in that wire. So you can take the second harder wire through the double lumen catheter. So single catheter but two lumens. And third is what you have told. Sometimes we can take two microcatheter, two wire, and this is called seesaw technique. This is also another parallel technique. But to make it simple, keep the first wire there, take the microcatheter out, and take the second wire by microcatheter. Thank you.
Yeah, a parallel wire is a very good technique. However, it depends also on anatomy, because if you have very tortuous artery, then double wire might enlarge dissection or produce more dissection. So I think this could be kept in mind. You should know the anatomy before selecting any technique to do.
Yeah, I totally agree with you. For doing CTO, two things are important. One is anatomy of the CTO, which is already told by my previous speakers, the proximal cap, distal cap, and course of the CTO. And second is you feel while you're passing the wear, how do you feel? So when you feel resistance, buckling, then it's time to change your wear. But if even you are not trying to cross the lesion, there is a buckling, and if it is out of the vessel structures, and even you're trying, then you are making the dissection more, and it can cause intramural hematoma and collapse the distal lumen as well.
Thank you for a nice deliberation, and you are a CTO guy also. So regarding
I always learn from you, medicine, surgery, gynae. You're my first boy.
So what about the knuckle wire? Which one is your choice of wire when you like to do intentional knuckle or accidentally it becomes knuckle, then you push through the subintima and ultimately goes into the lumen? Which one is the best wire do you prefer to produce the knuckle wire?
Knuckle wire is a dissection and re-entry method. So usually we use polymer jacketed wire. Either Fielder XTR wire is my favorite one, Fielder XTR. I can use Pilot 50 or 100, or maybe sometimes Whisper as well. But now there is a dedicated wire from the Asahi intake. This is Gladius. So this is only for knuckle they are made.
Gladius Mongo.
Gladius Mongo. But in knuckling also you use through microcatheter.
Yes, of course. Thank you.